It's my honor to join this incredible panel and talk a little bit about providing evidence-based care for cisgender sexual minority women, and just starting to either build for the first time or build upon a foundational understanding. Whenever you're tasked with speaking about a whole population, it's really just, an impossible task in a short period of time, because we're all learning about humans and our incredible diversity and variability. And I'll just say, so I use she and her pronouns, and this is relevant for me, this particular topic, personally and professionally. I identify as a white, Jewish, cisgender, queer woman. Sometimes I use the term lesbian, sometimes masculine of center, mostly queer though. And I'm partnered with a woman, I have a kiddo. And a lot of what I'm talking about is sort of a community that I belong to, but it's actually many communities and also many facets of communities that are actually very understudied, underserved, and vulnerable to poor health. And I'll speak just a tish about that, but just to acknowledge that. I have no relevant disclosures for this particular presentation, but I am funded in various mechanisms for some of the research that I conduct. And today's objectives, I'll really be talking about some defining and epidemiological considerations of cisgender sexual minority women. I'm so grateful to all the other speakers, to Hans, Tandy, Jen before me, for laying just such a powerful foundation for me to build on here. And I'm using the term cisgender. I'll speak about that for a smidge for those who haven't heard their talks, but talking about sexual minority women and some of the evidence-based medical needs for presumably cisgender, lesbian, and bisexual / sexual minority women, and build some foundational pieces of how to create a clinical environment. This is an ongoing journey. I would say that every day I am still learning and thinking about this with people, with patients, and with other clinicians. So this is by no means set in stone, but hopefully get some ideas flowing. So terminology, a lot of folks have really talked about this difference between sex and gender, or sex assigned at birth, and all the multiplicities of kind of what goes into sex and what goes into gender. And I will just say, rounding that out, that if we're thinking about sex as, or sex assigned at birth as, the biological and physiological characteristics that define phenotypes of our species as males and females, and actually much broader categories probably, and gender as socially constructed roles, behaviors, activities, and attributes that a given society thinks are appropriate for people of different genders. It's the sort of one definition from the dictionary says men and women, but we've been hearing a lot, obviously not just binary genders. But I will just say neither of these, neither one, somebody's sex, however that's come to, or gender, however that's understood, determine one's sexual orientation or sexuality, and who they're partnering with, who they're attracted to, and who they're sexually engaged with. All of these things actually need to be asked. That is the gold standard, whether it's asking about somebody's gender or asking about somebody's sexual orientation. And so to dive in here a little bit more into sexuality and sexual elements, as a researcher and as a clinician, I find it helpful to think broadly, disaggregate into three big buckets. And there are actually more than this, but helpful to think about how somebody identifies themselves. So how do they think about themselves and their sexuality? And that's a question you might ask, do you consider yourself, or how do you think about yourself sexually? What terms do you use for yourself? That is an identity question, versus which genders of people are you having sex with? What organs are going where? Generally spoke to this. Sorry, Dr. Hastings, good friend of mine. It's a little hard sometimes to use the honorifics, but I will, to honor incredible contributions in medicine and science. But what organs are going where? What fluids are going where? These are questions around behavior, and they have important health characteristics and health implications in terms of pleasure, as also in terms of infection, in terms of family building, these considerations. And that's different yet again from which, who are you attracted to, genders of people, and or bodies, body shapes, contours, sizes, colors. I mean, these are all pieces of attraction that we need to think about. And we usually don't ask about all of these at all or certainly in a disaggregated form. And this is important because we actually know that when we ask about all these different elements, they are not always quote unquote lining up in ways that we assume in medicine, that somebody's identity, their behavior, and their attraction are going to kind of all line up to arrive at talking about the same person or group of people. And all of these actually have health implications. And so when we look into this, thinking about cisgender sexual minority women, I'll define that term in a moment, but those terms, but we see that 9% of women report ever having a same-sex partner. That's actually an old figure, and I'll talk about epidemiology in a moment. It's higher among younger folks, and 10% of what researchers call, and how researchers talk about folks calling folks quote unquote lifetime lesbians, identifying 10%, up to 10% of our population as quote unquote lifetime lesbians, meaning they've never partnered with or thought about themselves or attracted to folks of a different gender, and then 90% as quote unquote adults. So after sort of sexual debut and after once they hit adulthood. But 30% of lesbians, these are cisgender sexual minority women, and I'm realizing I should have done definitions a little earlier, are sexually active with women and men. And so again, just speaking to, we make a lot of assumptions in medicine that these kind of components will all line up together in a particular way. It's okay if they don't. It's just our assumptions that are really faulty here. And we see this in youth, that actually a quarter in a big study, National Youth Risk Behavior Surveillance Survey, that of the folks who identified with an LGB, so lesbian, gay, bisexual identity, a quarter of them no same-sex contact, and some of them even, no desire for that, but were claiming that identity. Whereas of those who endorsed a same-sex sexual contact, among those who had initiated any kind of sexual contact, a third of them identified as straight. So again, just driving home this point. So here, this slide that probably should have gone a tish earlier is, I think many of us feel like we're familiar with the terms lesbian and bisexual, but just to say, lesbian is generally thought of as a woman whose primarily sexual orientation is towards people of the same gender. And just to take a moment and grok the fact that it's actually both a gender term and a sexual orientation term kind of mashed together. And that when we're doing that, what we often invisibilize is that women of any body conformation, any anatomy could be a lesbian. So that's cisgender women and trans women. And unfortunately, in our research, what we find is this assumption that people are that we're talking presumably about cisgender women. And that's super problematic because there's this whole huge, beautiful population of sexual minority transgender women who we have like no information about, at the intersections of sexual orientation and gender identity. So unfortunately, really the bulk of my talk really speaks about cisgender sexual minority women, and even more specifically lesbian and bisexual women, because there's really hardly any data on the diversity of sexual orientations, who people are partnering with, how they're identifying, and who they're having sex with as basically not straight. And it's almost always presumably or presumptively cisgender folks. Bisexual is an interesting term in that, again, I think a lot of people, if you ask people, what does it mean? People say, I know what it means. It's a person whose primary sexual orientation is towards someone of the quote unquote opposite gender. I think Hans' brilliant sharing a knowledge with us around these ideas of, how is this oppositional binary codification of sexes really come to be? And so there is this idea that in the term bisexual, there's an assumption of two genders. So some people who claim the term bisexual actually speak about it as to another gender and not just quote unquote the other gender, recognizing a bigger spectrum. But many people also use terms pansexual. There are also many other sexual orientations, asexual, polysexual. I mean, there's many different sexual orientations that again, the literature is unfortunately very impoverished. And I think I've spoken a little bit to speaking about that there are sexual minority women who may be cisgender or transgender. Predominantly, the rest of my talk really focuses on cisgender sexual minority women, and unfortunately lesbian and bisexual women, because those are the data that we have right now. So this is really just saying to acknowledge that in academia at this point that we use the term sexual minority and sexual and gender minority as a big umbrella term. It's used in academia, not really by communities, and that LGBTQ plus is a term most people are familiar with, but I tend to slip between them. So I apologize if that's confusing. And to underscore what others have said, using people's own terminology as a clinician and actually, I would say as a researcher, administrator, finance person is critically important. There's no single definition that's universally accepted, and things vary geographically, individually, and over time. So some folks may say, well, why ask? Why ask about sexual orientation? I think we've heard about why ask about gender identity, but I will say, sexual orientation, there are many folks who are LGBTQ plus in this country. And if we're thinking about sexual minority people as people who are not straight, basically, not heterosexual, we have terrible data. We're not asked on the census. The American Community Surveys are big instruments, but we have some good data from Gallup for people who felt comfortable answering a random digit dialing saying, or do you identify as LGBTQ plus, or LGBT is actually how they framed it. Not everyone feels comfortable answering that, but in last year's Gallup poll found that around 5.6% of the general population, all US adults, LGBT, and this varies according to generation. So we see the highest proportions in our youngest generation. So Generation Z, almost 16% identifying as LGBT, which is, we've got hope for the future. But that's different as it got disaggregated in terms of bisexual, gay, lesbian, and transgender. I think what's a little problematic about this second set of numbers in this second table is that it assumes that people are either in this bisexual category, the gay category, the lesbian category, trans category. And again, as I mentioned, you can be a trans person who lives as a woman and identifies as lesbian, or lesbian and gay, or lesbian and gay and bisexual, and so the data in the Pride study we have, depending on our particular slice and look and at different times, in any one of our studies, you can have between 6 and 40% of people choosing multiple sexual orientation options and multiple gender identity options. So poor and or exciting options here in terms of thinking about the data that we have. But what we know from studies that have asked about sexual orientation and gender identity in youth is that sexual minority, especially young women, young adolescents, increased violence, increased drugs, increased early onset of sexual activity with decreased either access or use of birth control. So increased, therefore, unplanned pregnancies or unintended pregnancies. And all of this really comes down to access and comfort, the stigma and discrimination and that one faces when encountering medical care. And we see this in older adults as well. So this is from another population study, a little bit older, but still very good data, and looked at a proportion of lesbian, gay, bisexual, and straight older adults' health outcomes by looking at gender and sexual orientation, comparing women and men. And basically in every one of these categories, you can see in the blue lines here that women who are lesbian, gay, and bisexual compared to their straight counterparts fared worse. So in poor physical health, poor mental health, disability, obesity, asthma, and diabetes, which is actually very staggering if you think about it. All the other health considerations, we often focus on, sex or sexually transmitted infections, these things, but really we're talking about general health considerations. And why is that? It's because of living in a world that doesn't see you and doesn't want to see you. And when it does see you, gosh, just not welcoming. And that's been termed by researchers as minority stress, but that's how it all comes down. It's very real, it's very practical, and it's very harmful. So I'm going to play this short video that I hope speaks to this experience a little bit.
As the American public ages, so do lesbian, gay, bisexual, and transgender people. LGBT older adults face the same challenges as other older adults, including financial worries and health.
sorry. Uh-oh.
As the American
Sorry.
public ages, so do lesbian, gay, bisexual, and transgender people. LGBT older adults face the same challenges as other older adults, including financial worries and health concerns. But LGBT older adults face additional challenges. Let's compare two women, Tina and Jackie, who were both born in 1947. In 1967 at college, Tina meets Frank and Jackie meets Francis. On a date with Francis after work, Jackie is seen by a coworker who tells their boss. Jackie is legally fired and takes a lesser paying job at a factory. In 1973, Tina marries Frank, but Jackie is unable to marry Francis. In the 80s, Tina and Frank have children, but Jackie and Francis are barred from adopting. After decades of hard work, in 2010, Frank and Francis retire. Tina takes Social Security spousal benefits. But because the federal government didn't recognize same-sex marriages then, Jackie is denied those benefits. In 2015, right before the freedom to marry becomes available nationwide, Frank and Francis die. Tina pays for her in-home care with her Social Security survivor benefits and funds from Frank's pension. Jackie is denied Social Security survivor benefits, and because she was not a legal spouse, is also denied Francis's pension. Their apartment was rented in Francis's name, and her state lacks non-discrimination protections in housing, so Jackie is evicted when she tries to change the lease into her name. Lacking an income and a place to live, Jackie moves into a nursing home and relies on Medicaid to pay for it. She fears discrimination if she shares stories about her past, so she doesn't talk about her life with Francis. Tina can afford in-home nursing care and has the support of her children. After a lifetime of discrimination, LGBT older adults face economic insecurity, poorer health, and reduced support networks. Find out more about the unique disparities facing LGBT.
So I hope that video helps illustrate just a few of what we would call the social determinants of health and how this experience of living in a world where the intersection of laws that are not recognizing you, social experiences come to pass to influence medical care and one's lived experience. And a lot of people will say, gosh, what's the big deal, Juno? There's like, you can marry in every state. And I'm like, wow, first of all, not everyone wants to get married. And B, it's so much more profound than that in terms of how stigma and discrimination played out. And so on your right, actually, there's this little banner and image that was put out by the Center for American Progress right after the Defense of Marriage Act was struck down. Basically says, congratulations, you legally marry on Sunday. That night, you're legally denied a hotel room on your honeymoon because of your sexual orientation. Monday, you're legally fired from your job. That's actually changed since this infographic came out, but people are still unfortunately finding ways to do that below board. But on Tuesday, you're legally evicted. That can still happen in most states in this country. You're legally denied a loan because you're married to somebody of the same gender. Your child is legally expelled from college when you notify the school of a new legal parent. And on Friday, you file a complaint because, but learn that you may not be protected from discrimination you have faced. So basically, there's so many other ways in which sexual orientation discrimination plays out, and that factors into people's health. And so what was done here was a study by some researchers looked at actually the quote unquote natural experiment of what happened before and after the Defense of Marriage Act. And they found that in states where there was legal marriage protections before it was the law of the land, they actually found that in states where there was no legal protections, there was 2 times higher suicide risk. And mortality risk was elevated, and marriage, where marriage was recognized, there were lower mental health disparities, and where there were states that were actively banning marriage, there were increased psychiatric diagnoses. And so this is what we mean when we talk about minority stress, and this is why political advocacy and activism is actually so fundamental, because this directly influences people's health. Now, I'm just going to give a smattering of other health experiences. Again, I can't cover everything, but just to give you an idea, some things that might be surprising. So intimate partner violence rates might be higher, and challenges differ. And so it's, unfortunately, I'm not trying to say that there's a competition or race to the bottom of kind of which group is having higher experiences of terrible outcomes. But in one study, 44% of lesbian women, 61% of bisexual women, and 35% of heterosexual women is really, I think, confounds a lot of people's notions of what it means to be in a same-sex coupledom, for example. And why might that be, and how might that manifest differently? So one of the ways in which it might manifest differently is unwelcoming shelters. So imagine if you are in a same-gender couple and both the traditionally considered perpetrator as well as survivor both go to that same facility. And then, how does that facility care for or know how to handle that situation? There may also be a component of outing individuals, okay? And unfortunately, until recently anyway, somebody could lose their job. So people could hold over somebody's head, gosh, I'm going to tell your boss that you're a lesbian, and gosh, you're going to be fired because of that. So another form of violence and how violence is enacted, and even the patterns of violence and discrimination violence, intimate partner violence may manifest differently. And leaving may pose different challenges. Unfortunately, as we saw in the video, the socioeconomic status of individuals may be quite different. And so the safety net that people have, the network that people have to rely on might be different, even how many children they have or how much their kind of natal family or chosen family can support them might be different. And so options for leaving an abusive situation might be quite different as well. Another thing that's often talked about are health disparities in terms of alcohol and drugs, that there's increased alcohol and drug use among cisgender, lesbian, and bisexual women. And again, I really want to underscore this is not an inborn issue, but really as a result of, we think, of minority stress, as well as structural considerations. So here's a picture of a famous LGBT plus bar, and for many in many places and many years, and still to this day, there's certain settings that were kind of okay for people to gather, and some of those were bars. And so if that's the only place where you can sort of safely, more or less, find your people, then that, and that environment is always drinking or smoking or other things, that may increase the likelihood of using those substances, in addition to things like self-medication for the experiences of stigma and discrimination. And so what isn't studied as well is what works for LGBTQ plus folks or sexual minority women in terms of quitting alcohol and drugs. We have some data about gay-straight alliances or adaptation of services, but we need to recognize that this is a real gap. We know that social structures make a big difference in terms of health and how people change use patterns around substances and why they might be using them in the first place. We need to think about those same things as we develop interventions to see what works to make them culturally real and relevant for the communities that we hope to serve. And that also translates to tobacco use. So when we look at LGBTQ plus communities as a whole, we see much higher tobacco use. And cells don't care what your sexual orientation or gender identity is. We know that smoking is bad for kind of all parts of our body, but how we got to be smokers or not varies. And there were actually very specific campaigns by the tobacco industry. RJ Reynolds, for example, had one that was called Project Scum, and that stood for subculture urban marketing that targeted LGBTQ plus people specifically, as well as people who were marginally housed or homeless, and to get them addicted to their products. And so in addition to the sanctioned socialization, and then there are also media interpretations and sort of the hypersexualization of smoking, all these other things that really targeted and resulted in the fact that 1 in 3 LGBT people smoke versus 1 in 5 in the general US adult population. Again, higher in bisexual women, lesbian women than straight women. Again, this is among cisgender women that we have these data. But some protective factors seem to be community connections and friendships and sort of belongingness. We also see a lot about body weight and inactivity, unfortunately often posited first as blame towards individuals and a lack of distinction between body weight and fitness, which I think needs to be delineated a lot more. But talking about inactivity, we find higher inactivity and higher BMI than straight women. And one of the things that has been kind of tied to this is less likelihood to participate in team sports and meet national guidelines as youth. And setting that pattern really early on, because unfortunately locker rooms are a place where a lot of discrimination and discriminatory activity can happen. We also see kind of a different perception of self and body, which could be perhaps very powerful and positive in terms of breaking down stereotypes of a drive for a certain type of image that may be unhealthy. But we still need to do a lot more work around that. There are differences in perception of what a healthy body weight seems to be. But we really have limited fitness and weight intervention data. How do we understand how to get to a healthy weight for individuals? And what's the community perception there? And how do we engage things like the halo effect in community interventions? We've also seen kind of differences in heart health. The risk of cardiovascular disease seems to be higher in sexual minority women. And that's taking some of the other things that I've just talked about. So higher smoking, inactivity, and obesity combined are three of the major risk factors, combined with elevated lipids and diabetes for cardiovascular disease. So if cisgender sexual minority women tend to have three of those, then we're already at a setup for poor cardiovascular disease. We also find older vascular age, and that seems to come from kind of this stress plus those other three risk factors that I just spoke about, as well as things that I haven't touched on at all and don't really have time to, sadly, but stress and stressful life events. So job loss, discrimination, homelessness, lower socioeconomic status, all of these tend to age us cardiometabolic. But some good studies saw that hypertension seems to be the same. So the one that we tend to focus on as doctors, it really doesn't seem to be the difference, but all these others that really manifest mostly through socioeconomic status do seem to be quite different. Gosh, I need to speed up. So also differences in terms of pulmonary disease, seems to be higher asthma and somewhat concurrent maybe with smoking and obesity, but even in studies that correct for that, in other studies, we still find that. So this is one that comes up all the time, breast cancer. And really, I would say from looking at a lot of the data, I think that the literature is mixed and it's unreliable, partially because of the inconsistent asking about sexual orientation and gender identity. But there's some good reason to think there might be differences. So differences in nulliparity, in alcohol use, obesity or overweight, and smoking. And perhaps I think a really important one is less access to care. So not just in terms of screening, but at all components of treatment, so screening, diagnosis, treatment, and then secondary, tertiary prevention. I want to point out this one that we really are seeing. It's more qualitative, but it's really just profound to me, is that there may be real differences in desires for treatment. So this has come up with a desire for just different surgical approaches. And I think we don't pay enough attention to this, that, for example, a desire to have an aesthetically flat closure, and that some people, and this is not just among sexual minority women, but that some people may not want a reconstruction with implants or nipple reconstruction or whatnot. And some, unfortunately, surgeons have fought people on that. And so this is actually, these are a couple, Emily Jensen and her partner, Jody Jakes, who both had cancer, both cancer survivors, and both decided to undergo flat aesthetic closure with no reconstruction by choice. And that was what felt right to them. So switching gears a little bit towards family building, this is an area I like to think about a lot. What we also have limited data on this, and I'm working on that with some colleagues of mine, Dr. Stephanie Leonard, Dr. Iman Barahu, Dr. Main, and others, just trying to understand really what are the patterns around family building. We have again, a paucity of data, but some studies look at, if around 3/4 of adult cisgender women are parents in some form, some studies say that about half of LGBT plus women are raising kids. That's higher among bisexual women. And that there's just many, many paths to family building. So there are things like co-IVF, which is something that I did with my partner. It's a very labor intensive in the sense of medically intensive path. We took her egg, I carried, and to build to have our son. But intracervical insemination, intrauterine insemination, penis and vagina sexual activity, fostering, adopting, co-parenting, I mean, many different structures. And there's very limited representation of these incredible diversity of ways to arrive at building a family and even what that looks like. And I think we have a lot of work to do. I think a lot of people say, gosh, well, if it's so hard, why not just adopt? Or, if you have to engage with all this medical care and you don't want to, or you can't afford to, or whatever, why not just adopt? And I just bring up this. So this is 2 days old. I made sure it was current. This is kind of how our country looks in terms of health disparities and state regulations on adoption. And so green is good here, state regulations that prohibit discrimination in adoption based on sexual orientation and gender identity, only 27 states, plus 1 territory in DC. And then the sort of lighter green, the state statute or regulation prohibits discrimination just on the basis of sexual orientation alone. The lighter is no explicit protections against discrimination, which when there are no explicit protections, it often means that discrimination is viable, and that's 19 states. And then these exclamation mark states, which just boil my blood. Actually, the state permits state licensed child welfare agencies to refuse to place and provide services to children and families, including LGBTQ plus people and same-sex couples, if doing so conflicts with their religious beliefs. So that's state sanctioned, that's government sanctioned, that's your tax money is supporting these agencies and saying, no, we're not gonna place kids that need homes with same-sex or LGBTQ couples. Now we live in a green state, right? So we're like, okay, cool, we're in a green state, but this is, just a smidge on my story. This is my kiddo when he was much younger. So I'm an OB/GYN, my partner's a lawyer, and we delivered our kiddo at UCSF, and we had to fight to get both of our names on the birth certificate, even though we engaged in what we call co-IVF, because they said only the biological mother's name can be on the birth certificate. Despite being, the good queer couple, we came with our stacks of paperwork. We had gone to a judge. We paid thousands of dollars to have a birth judgment before he was born, saying that this kid, uncontested, should have both of these parents' names on the birth certificate at the time of birth. And I don't know if you can see it here, but we had to cross out father's name to have Teresa's there. And then we had to threaten to sue first the city of San Francisco and then the state of California to get both of our names on the birth certificate, even though we had a legal parentage judgment. And we are incredibly privileged, affluent folks with money and a lot of professional privilege, and we couldn't make this happen without basically lawyering up in a serious way. So just, to think, that was my first thought after birth, is my kiddo going to have the right birth certificate, kind of thing, and are we going to be recognized? Just to talk about the other side of things, I talked about how sexual orientation and sexual identity, attraction, behavior don't necessarily quote unquote line up in the way people might assume. So a lot of people who might identify as a lesbian or bisexual or agender person may be having sex with sperm involved. And I write men here, but that's actually an old holdover. This is an older slide, but with sperm involved, people of any gender that could result in a pregnancy. And when I speak to folks, sexual minority women, lesbians, they're like, I'm so tired of being asked about birth control where it's not relevant. And then I have some other people being like, gosh, I wish somebody had asked me because I didn't even know that it was possible, or I usually never have sex with somebody with sperm involved. And I was like, kind of a one-off thing and I wasn't prepared, So I think the point is to really go into it openly. You have to customize what you're doing for the person in front of you and say, hey, if you have these body parts and you're engaging in this activity, it's a possibility. How do you want to go about that? How can I support you in meeting whatever your goals are, to build a family, to not build a family? We see actually in lesbian and bisexual youth, higher pregnancy rates, higher unintended pregnancy rates. And there's a lot of thoughts about why that is, maybe demonstrative heterosexuality and trying, or experimentation, trying to figure out, how does the identity, attraction, pleasure piece fit in? But all that's to say, there's an unmet need here, and we have to ask as clinicians. In the interest of time, I'm going to skip over sexually transmitted infections and say new CDC guidelines out. I still have to review them, but we do see higher chlamydia rates in young sexual minority women, and that all STIs can be transmitted from people with a vagina to other people with a vagina, and people with a vulva and uterus, ovaries and tubes to other people. So nothing's off the table is how I think about it. And I need to give you all the information I can about sexual infections. And that's true for cervical cancer prevention too. Basically, the guidelines are written such that it has nothing to do with sexual activity. We talk about age of debut, but really anyone 21 and over with a cervix needs to be screened regardless of who they're having sex with. So if you have an organ, screen it, is kind of how I approach it. But we know, because of discrimination, stigma, lack of access to care, that lesbian and bisexual women may be getting screened less often because they're reticent to go in. So think about your campaigns. Are your campaigns making people feel visible in who they are, who they're partnered with, and whatnot? So as I wrap up here, I would say, there's a lot of studies out there. Providers don't ask, but we should. We should ask about who people are supported by, just to know who our folks are. We should ask who they're having sex with, who they're partnered with, who they, who would help them pay the bills if something went south. These kinds of questions are important. Okay, and then I will wrap up with these things. So I like these three principles. Cisgender sexual minority women are different from cisgender straight women because of living in a world that doesn't necessarily see us in all of our difference. But we're also same as cisgender straight women. If we need mammograms, we need pap smears, we need general health care, but we're also unique from one another. I would never say, gosh, I've taken care of one cisgender pregnant woman, I've taken care of them all. So I wouldn't expect other people, to not give that diversity to cisgender sexual minority women. And then think about how you're creating, or not, open spaces for people. So how are you inviting people into your practice? What happens in your interviewing process that allows people to disclose all of who they are? How do you refer out to other people? So what happens between doors? And what do you do to not just, gosh, oh my gosh, somebody who's a lesbian or bisexual woman has come to me, but how do you actually make your practice a destination of choice, something that people really want to go to? So I am the co-director of the PRIDE study. We're trying to fill in the data gaps. Please check out our study. And we have a summit coming up about community engaged research. So you can check this out, click the QR code, it's in June. And thank you so much for your kind attention.